to having here tonight two good collaborators, long-term collaborators, Professor Jonathan Myers from Stanford University and Dr. Christina Grüne de Souza e Silva from Rio de Janeiro. She works with us in Clinimex. And the first topic that I would like to tell our friends that are going to listen to this audio or see this video is that it's a long-term scientific collaboration. May we have some slides to share, Christina, please? Okay, as I told you, this is a long-term collaboration between Clinimex and Rio de Janeiro, Stanford University and US, California, Palo Alto, US, and our presentations. So following the slides, we have, as I told you, a long-term scientific collaboration that has been quite profitable. We had over 10 papers, next slide, and publishing in American journals, European journals, Brazilian journals, and different sources in different times. It's a long-term collaboration. Maybe Jonathan, would you like to comment on that? How has been our collaboration in the past? Since we first met, I think 1994.
Yeah, in fact, Claudio, earlier than that, I think in 1990, I was at the ACSM meeting and you were challenging me a little bit about some of our ramp work. So I've known you for, that's 30 years now, right? So, and I think as I'll talk about in a moment, the database work that I've done with Vic Frelicker had over many years, since the mid-1980s, has given us the opportunity to collaborate with many groups, and you're one of them. So I'm lucky to have, I didn't realize there were 10 papers, but you know, I could also go to Mexico or Germany and find something similar with some of our collaborators like this that we've done 5-10 papers with. And certainly a particular group in Switzerland where we've done dozens of papers. So again, I'm very lucky to have had the chance to collaborate with you guys and so many other people.
Yeah, you have received some of our best students, and Christina was the last one that has spent some time with you in the lab, and she learned a lot. And we are very proud with the opportunity and very glad that you have received her. Vic Frelicker has received her. She learns a lot when she was at Palo Alto. May we move to our recent paper? Our recent paper, may we have the slide, is published online first at the American Journal of Cardiology. It's called the effect of beta blocker use on exercise heart rate gradient and reclassification of mortality risk in patients referred for exercise testing. There are a few authors that are not in this round with us. We are pleased that they have helped us, especially the first author that's from Germany. And Jonathan Myers was the senior author of this paper, responsible by using the Stanford data. What is exercise heart rate grading? We may have to explain this for our friends. Next slide. This was our original paper published in 2015. When we introduced this novel index to predict all-cause mortality. Jonathan Myers was one of the co-authors of this paper with us, helped us to make all the analysis and the ideas and so on. And then what means exercise heart rate grading? Let me explain that. In the following slides, we have some explanation of that. We know that heart rate at rest, a heart rate, maximum heart rate, and heart rate in the first minute of post-exercise are all important in terms of epidemiology. They all are good predictors of all-cause mortality. But if you could combine them in a single one value, would be interesting. Then we move to that. Next slide, please. In 3 steps, we did that. First, we have reduced from 3 to 2 variables. How we did that? First, we calculate heart rate reserve. That's heart rate maximum minus heart rate at rest. And we calculate delta heart rate at recovery. What does it mean? Heart rate maximum minus heart rate in the first minute of a post-exercise. With these 2 variables, we move ahead and we start in looking our lab's data set and calculate quintiles of our distribution for these 2 new variables. And we are able to attribute the score for individual patient results in quintiles. What does it mean? Quintile first, score 1. Quintile, second quintile, score 2, and so forth. The quintile 5 is score 5. So we have quintiles, 5 values for heart rate reserve and 5 values for 1 value for heart rate recovery. So we can add both of them, that's the third step, and we could come to exercise heart rate gradient. That ranges values from 2 to 10. Then, explaining that, we got the table in our original paper showing the first, second, third, and fourth, and fifth quintiles for both variables. And then was interesting to see in the next slide that the distribution of our scores in our sample, original sample, was pretty good. We have all the scores. That's helped us to obtain quartiles and make good Kaplan-Meier analysis and Cox modeling for all-cause mortality. And the results were very interesting. Those scoring 7 to 10, where most of them were alive long-term, especially in the first 2 years. We have very, very few cases of that. As compared to the exercise heart rate gradient score of 2, much worse prognosis. And it's interesting, the exercise heart rate gradient in our study had a better performance in terms of all-cause mortality prediction as compared to one of each variable. And looking for the modeling, age adjusted, we have over 3 one result over 3.2, highly significant. So it was a very good discriminator in terms of all-cause mortality. And the conclusion of the paper, exercise heart rate gradient was a better discriminator of mortality than each one of the variables that generate exercise heart rate gradient. Now, it's interesting to see how these perform in different samples. So, Christina, is it with you now?
Sure. So as Dr. Claudio stated previously, this novel index that was termed exercise heart rate gradient was a better discriminator of overall mortality risk than heart rate reserve and heart rate recovery alone in this Brazilian population. In this current study published in the American Journal of Cardiology, we studied the exercise heart rate gradient. So this index responds to exercise in a different population, which was at higher risk of cardiovascular disease. So the study population consisted of almost 3,000 veterans, mostly men, who underwent a treadmill testing. And a relative novel method for quantifying change in risk that was termed net reclassification improvement was performed, and to evaluate the impact of heart rate reserve, heart rate recovery, and exercise heart rate gradient on all-cause mortality. And it was interesting to see that what was found was that when stratified by quartiles, exercise heart rate gradient was an overall powerful discriminator of risk, and it remained a strong predictor of mortality even when fully adjusted for conventional risk factors. So among individuals, patients without beta blocker therapies, adding this index score to an established model that included multiple baseline risk factors and exercise capacity resulted in a net reclassification improvement of more than 14%. However, among patients that were on beta blocker therapy, the addition of this index of the exercise heart rate gradient did not result in any significant reclassification. So concluding, the exercise heart rate gradient was superior to both heart rate reserve and heart rate recovery in predicting mortality, and provided significant reclassification of risk among individuals that were not taking beta blockers. So this extended previous findings of what Dr. Claudio just previously described to us.
Great. We have, as we mentioned before, we have different times in our life that we have met. We even have some common friends around the world, like Jari Laukkanen from Finland, Vic Frolicker when I visit there, even in our Búzios beach here in Brazil. That's fine. We thought we could combine science and some leisure. And during this running on the beach, we had very nice physiological and clinical discussions about exercise testing, all the variables. So John, before to end, what will be our next steps? I was thinking maybe if you look for older subjects that have higher prevalence of coronary artery disease and they are in higher risk, and are the subjects where perhaps you have very, very clear decline of our maximal heart rate. Maybe there's not linear heart rate, maximal heart rate decline with age. Maybe it's more steeper when you look for older people. The same happen maybe with the recovery heart rate. They have a changing autonomic nervous system. Maybe they do not perform well. Should we look for these age subjects in particular, and maybe we could combine cardiorespiratory, or as I likely to call aerobic fitness, to see if they combine and they add one to the other, or one is better to the other? What do you think will be our next step to enjoying our data sets?
Yeah, Claudio, I agree with that. And let me just add something. As our graduate student, Suting Wang, just deserves mention. She came from Munich about 1.5 years ago and kind of went to town on this database. We suggested this because the EHRG hadn't been really looked at in a more clinical population, and we were very interested in the effect of beta blockers. And just incidentally, I agree with what you said, that, you know, what's interesting is after all these years, it's still a little controversial, the impact of beta blockers on heart rate recovery and chronotropic incompetence, and you know, some of these things. So I think that's important. And then with EHRG, like with anything else, it becomes important when it's replicated, and is it portable? Does it work in the Women's Health Initiative study? Does it work in Brazil or the United States or Canada? And once we put something out there like that, it's important to try to replicate findings. As Vic Frelicker always told me, science is replication. So it's not just one study, it's always something you have to repeat and look at and keep repeating. And it's research is a grind. And then you come to a kind of a reasonable consensus about what something means. And never say that your data proves something, because it doesn't, because it needs that replication. It needs to be massaged in other populations, older and younger people, people with and without beta blockers or other drugs or whatever that might be. So we've sort of scratched the surface here in a South American and a North American population, and we have more work to do.
Sure. Christina, would you like to add something about your experience there?
Yes, I would like to thank Dr. Myers for having me for over a year in VA and Stanford. It was a really nice opportunity. I stayed there for doing my part of my PhD studies. And I'm very grateful because I met wonderful people and I was able to, well, study a lot with you. It was really an honor. Thank you.
Yeah, there's a nice pictures, nice reminders.
Yeah. John, it was a pleasure to have you with us for this video and podcast. I hope you have a chance to publish other things, and we have a chance to do some other videos sharing knowledge. I know that you love to share knowledge. I do as well. Mm-hmm. So there are a lot of people interested in knowing more. So we can do this once in a while. Maybe we'll repeat later. Thanks again for sharing this podcast with us. Christina, again, for organizing that. Keep in touch.
Thanks. Thanks, Christina and Claudio. Great to talk to you and to do this with you.
Thanks, John. Thanks, Dr. Claudio.